म्यूट अच्छा Okay. Good afternoon, everyone. I'm Dr. Vishwanath. I'm consultant neonatologist and pediatrician, KIMS Cuddles Kondapur. So today we'll discuss an important aspect in NICU, which is analgesia and sedation, and how to go about it. So to start with, uh, till 30 years back, all preterm neonates undergoing major surgical procedures, um, there was no analgesics used in perioperative or post-operative period. So all abdominal surgeries and other major surgeries which were performed were without without any sedation. So historically, if we see, there is a considerable debate uh, uh, when we take into consideration neonatal pain. It was felt that neonatal pain is subjective and it is decorticate in nature, and there is no localization of pain in neonates, and they don't remember or have the memory of pain in neonates. But then there was a landmark study which not study, but there was an article which was published in 1987 in NEJM, where Dr. Anand published pain and its effects in the human neonates and fetus, where it was emphasized that neonates and fetus as early as 20 weeks can feel pain. So the nociception and the associated physiological effects occurred in lowest limits of human viability. So this was a landmark article which was published. So why pain is important? On a day-to-day basis in NICU, we perform 10 to 15 procedures in a day. So this affects the neonate's sleep associated with some behavioral changes in terms of change in heart rate, saturation, vital parameters. There's some feeding disruptions as well. And behavioral change, they show some facial changes. And it is also associated with some long-term neurodevelopmental effect that we will see what neurodevelopmental effect of pain. So I'll start my presentation with a little bit of pain pathway, and then what are the objective measures of pain in NICU, the procedural analgesia, the pharmacotherapeutics drugs, what are currently available, and the concept of weaning and the withdrawal with analgesics and sedatives. So here you can see neonatal, it's a pain pathway in adults and in pediatrics. Let's first see how the pain is transmitted. Any noxious stimulus is carried by, once again. So here you can see any noxious stimulus is carried by pain fiber C and A fibers and to the dorsal horn of spinal cord. From the spinal cord through the spinothalamic tract, it reaches the cortex in the areas of somatosensory cortex, thalamus, and the limbic system, which then is perceived as pain. There are few few things which are different in neonates, like the NMDA. The first one being the NMDA receptors on this dorsal horn. They are larger in size. So the stimulus which reaches the spinal cord are a significant amount. And the GABA receptors, which are usually inhibitory effect on the glutamate, is excitatory in neonates. And the third one is the descending fibers are not myelinated or they are not generated. So these all contributes to a lower threshold for pain in neonates, and the pain intensity is greater, and there is poor localization of pain, which results in all the behavioral changes, vital parameters change, feeding disturbance, and the sleep disturbance in neonates. So, uh, so there are many tools available which can assess and quantify pain. So there is observational pain scales, neurophysiological measures to assess or quantify pain. Then there are endocrine parameters which can quantify the pain in neonates. And there are few units who quantify pain in terms of number of invasive procedures to which a neonate is subjected in a day. So as you can see, there are many observational scales available, like Bernese pain scale, Comfort Neo, Neonatal facial coding system, the revised one, Neonatal infant pain scale, the NPA scale, which is commonly used, Neonatal pain, agitation, and sedation scale. And the most commonly used is premature infant pain profile revised. So they use post-menstrual age, and in the context of acute pain and chronic pain. The components usually most of it uses all the three components: physiologic component, behavioral components, and the contextual. Physiologic components includes respiratory rate, heart rate, changes in oxygen saturation, skin color, and the behavioral pattern component includes changes in facial expression, excessive cry, and the few facial features like brow bulge, eye squeeze, and the nasolabial furrow. And the contextual component includes the behavioral state of the neonate, the gestational age, the state in which the neonate is, and then a score is assigned. So if you see, there are a lot of observational scales available. But then now, which scale to be used? Which one to use? So there was a systematic review conducted by Emma et al. In 2021, which showed most of the studies which used, concerned with procedural pains, they showed that the premature infant profile and the premature infant pain profile, a revised version, was used in most of the studies, which was followed by neonatal infant pain scale. So most commonly used was the revised version of premature infant pain profile. So let's see and try to understand how this scoring system is done for the quantifying the pain. So so there is infant indicator, which includes vital parameters like heart rate and oxygen saturation. And then there are behavioral parameters like brow bulge, eye squeeze, and nasolabial furrow. And these parameters are given a score, an indicator score of 0, +1, +2, and +3. So if you see, for example, the change in heart rate from baseline, suppose for a neonate, the heart rate is around 160. And during the procedure or post-procedure, the heart rate increased to 164. So it will be given a score of 0. The more the change from the baseline, the higher the score is. Okay. So +1 for change in heart rate from baseline from 5 to 14, and +2 if the change is around 15 to 24, and +3 if the change is more than 24. Now, same thing with oxygen saturation. There will be decrease if the decrease in saturation from baseline in terms of percentage is 0 to 2, then the score is 0. And if the change is from 3 to 5, the score is +1. And 6 to 8, it's +2. And more than 8 or increase in oxygen, if at any point of time we are increasing the FiO2, then it is +3. Now, coming to the behavioral indicator, which includes brow bulge, eye squeeze, and nasolabial furrow, they are measured in terms of seconds. For how much long, for how much duration these indicators are present. So, if it is less than 3 seconds, it is scored 0, +1 if the the change for 3 to 10 seconds. It is scored +2 if it is between 11 to 20, and if it is more than 20 seconds, then it is given a score of +3. If any of these two, after including infant indicator of heart rate, oxygen saturation, and behavioral response, if any of the score is above 0, then we have to include this gestational age and baseline behavioral state into consideration. If it is 0, then we don't include gestational age and behavioral state. So the subtotal for physiological and facial indicators, if score is more, we add gestational age and behavioral state. Okay. So the instructions while performing this scoring system, you have to observe the neonate for 15 seconds at rest and assess the vital signs to establish the baseline heart rate and oxygen saturation and the behavioral state in which neonate is. Step 2, then observe the infant for 30 seconds after the procedure and assess the change in vital sign indicators. We have to see the maximum heart rate the neonate has and the lowest oxygen saturation and the duration of the facial actions, brow bulge, nasolabial furrow observed. And if any time there is an increase in the requirement of oxygen, then the score of 3 is given. And step 3, score for corrected gestational age and behavioral state if the total subscore is more than 0. And the total score is calculated by adding up of subtotal score and the behavioral state score. Okay. So this was the premature infant pain profile revised version. It was revised because the earlier version of PIPP was a bit cumbersome and it was difficult to calculate during or post procedure, because the parameters like oxygen saturation were in terms of decimals. If you can see, the change in oxygen saturation was 0 to 2.4% decrease. It was difficult to calculate. And similarly, the behavioral score of brow bulge, eye squeeze, and nasolabial furrow, it was in terms of percentage, it was very difficult to calculate. And so the scoring system was changed, and that this revised version was introduced, which is much easier to score. Now, these are all the scoring system. So there are other parameters through which neonatal pain can be quantified. There are parameters like near infrared spectroscopy, NIRS, and EEG. So NIRS, it detects the changes in cerebral oxygenation. But the drawback of this is it do not quantify the cumulative exposure to which the neonate is exposed. EEG, on the other side, detects the cortical neural activity in response to this painful stimulus, and it can discriminate both noxious and non-noxious stimulus. And in many studies, it has shown to be a good methodological consistency was good with EEG. Basically, these two are used for research purpose, but in clinical practice on day-to-day basis, we can use the scoring system of premature infant pain profile. Of late, there has been use of functional MRI. In functional MRI, it has been shown that the greater amount of pain is associated with decreased functional connectivity between the thalamus and the sensory motor cortex. It leaves an image, something called as pain signature in those areas. So this also is for research purpose. Neonate in response to pain, endocrine response to pain is by the activation of hypothalamic pituitary axis. It has some stress response, and this response is measured by cortisol in saliva and hair. And this also has been used to quantify pain in neonates, but in few studies it has been done. And it also has been shown that there is an altered physiological stress response and behavioral problems in childhood, increased cortisol levels. And few units have been using the number of invasive procedures as a measure to quantify the pain. But it does not, the drawback of this is it does not assess the pain intensity or the physiological response to the painful stimulus. Okay. So now we have parameters to quantify pain. Now we'll see what is the analgesia we usually give to neonates. So for mild to moderate pain or for any minimal invasive procedures, we prefer non-pharmacological interventions. So there are many non-pharmacological interventions like non-nutritive sucking, breast milk, skin-to-skin contact, kangaroo mother care, which we commonly do, facilitated tucking, giving the neonate developmental supportive care, making comfortable. And sucrose. Sucrose has been used widely for mild to moderate pain or minimal invasive for minimal invasive procedure. So sucrose, if we see the evidence, sucrose, the oral administration of sucrose prior to heel lance and venipuncture and any other IM injections, it has been shown to reduce parameters like crying, facial grimacing, and the motor activity. There has been definitely a proven benefit for behavioral response, but there has been no impact on oxygen consumption, energy expenditure, the stress levels, the cortisol levels in saliva and plasma, and the neural activity of nociception evoked the circuits in spinal cord or brain. So it has no impact on that. Just predominantly the behavioral response, and there is no benefit for neurodevelopmental impairment at 18 months of age. So there, Cochrane has been published on sucrose for analgesia in newborn infants undergoing painful procedures. This was published in 2016. It said that there's a high quality evidence for the benefit of sucrose, which is 24% sucrose we use, with non-nutritive sucking, pacified dipped in sucrose or a 0.5% of sucrose orally in both preterms and term neonates. So there was a high quality evidence, and there was high quality evidence for the use of 2 ml 24% sucrose prior to venipuncture, single procedure. Sucrose is effective for reducing procedural pain from single events such as heel lance, venipuncture, IM injection in both term and preterm. And there was a moderate quality evidence that sucrose in combination with other non-pharmacological interventions such as NNS is more effective than sucrose alone. But there is research is needed. And a caution was given for the use of sucrose in extremely preterm, unstable, and ventilated neonates because still studies are yet to be done in these set of neonates. So invasive procedure. So now we have seen mild and moderate pain. So invasive procedures are usually painful. Most commonly, which we do is endotracheal intubation and sedation during mechanical ventilation. So, what are the pharmacological strategies which are available? Drugs which are available. So, most commonly used are opioids, of which morphine, fentanyl, and remifentanil um, are being used, and commonly being fentanyl and morphine. Very rarely we use midazolam in neonates, and there is a newer drug which has come, which is widely being used in adults and pediatric critical care. This is selective alpha 2 agonist dexmedetomidine. We will see. Um, so, if you consider intubation, what is the ideal drug we want for intubation? Any drug which is rapid in onset, there is shorter duration of action, and which has, of course, minimal effect on the respiratory muscle. And we have all these available options. So now, if you before deciding on which drug to use, let's see the pharmacokinetics of each drug. So if you see morphine, morphine is an opioid. It acts on mu opioid receptors. So it stimulates descending inhibitory pathways, and it is primarily metabolized in the liver by glucuronidation. Okay. Uh, if you look into the pharmacokinetic data, the onset starts somewhere around 5 to 15 minutes, has a half-life of around 10 hours. It has a predominantly renal excretion than hepatic excretion. With the dose, if you see the intermittent dosing of 0.05 to 0.2 mg per kg, starting with the lower dose, and the infusion dose of loading 0.1 to 0.15 mg per kg over 1 hour, followed by a maintenance of 0.01 to 0.02 mg per kg per hour. So there are few short-term side effects of morphine, like since it's an opiate, it causes meiosis. There is incidence of pruritus, respiratory depression, which we majorly are concerned in neonates. There is constipation, increased biliary pressure. There is urinary retention. We see that after stopping sedation, only we try to remove catheter in neonates because they tend to go have this urinary retention. There is hypotension, yes, decreased hepatic function, which leads to decreased metabolism and impairment of morphine clearance. And in renal impairment, there is a prolonged half-life of morphine. So next, moving on to the second drug, fentanyl. Fentanyl is a synthetic form. Uh, it also acts on pure mu receptor. It's an agonist, and it is more potent than morphine. And it compared to morphine, it has 75 times more affinity at mu receptors. It is very rapid. It has a very rapid onset of action, a relatively short half-life, and also it can be given intranasally. It is primarily metabolized by CYP3A4 enzyme in the liver, and it is being excreted by eliminated by the kidneys. The onset is very rapid. It onset of around 1 minute. The half-life it slightly varies from term and preterm. In term the half-life is 5 hours, and in preterm it's 9.5 hours, with a dosing of 1 to 5 mics per kg per hour. Unlike morphine, fentanyl does not cause much of hemodynamic instability, and it does not release histamine causing pruritus. But there is a side effect of chest wall rigidity, which is seen with fentanyl, which can be mitigated by slow infusion of fentanyl. And if we feel that chest wall rigidity is too much, more with fentanyl, then we have to reverse it by administering naloxone. There's a third drug, which is remifentanil, which is used by anesthetists, not very oftenly used in NICU. It's a very ultra short acting opioid agent. It also acts on mu receptors. It's a selective agonist. Because it is rapidly metabolized by blood and tissue esterases, it's ultra short acting. and it has a renal elimination. The onset starts around 1 minute. It has a half-life of around 5 to 6 minutes. There are few studies where it has been used in ensure technique in clinical scenarios where we give ensure, where we intubate, give surfactant, and then extubate. Uh, the long half-life of fentanyl may confound the attempts to immediate extubation. We expect extubation in 4 to 6 hours. So it might be affected by sedation if we are giving. And also, there is some chest stiffness with the rapid administration of fentanyl. There are few studies in which remifentanil was used, and uh, it showed that it improves the first attempt success when compared to opioid with a slower onset like morphine. So now coming to the last drug, which is a newer drug, dexmedetomidine. It is not an opioid. It is a selective alpha two adrenergic agonist. So it has an action of analgesia, anxiolysis, and sedation. So it has a potential to replace both opioids and benzodiazepines in chronically or mechanically ventilated preterm. Few as it does not cause any respiratory depression or any gastrointestinal dysmotility. It can be administered intravenously or intranasally. But there are big studies which are needed to ascertain the safety and efficacy before the universal use of dexmedetomidine is prescribed. It has a loading dose of zero point 0.2 to zero point 0.5 mics per kg per minute and infusion dose of 0.2 to 0.75 mics per kg per minute with a ceiling dose of 1 to 1.5 mics per kg per minute. So there is a review article which was published, I think, to 2023 or 24, in which they have mentioned dexmedetomidine is shifting paradigm in the neonatal sedation and pain control. So in this review article, they mentioned dexmedetomidine can be used alone or in combination with other agents. And by using this dexmedetomidine, it is possible to reduce the concurrent medications and thereby minimizing the risk of complications while still achieving the desired sedation and analgesia. So it can be used to decrease the dosage of concurrent medicines without any complications. So these were the short-term effects of analgesics. So do analgesics have long-term side effects? Let's see. Yes, there are long-term side effects, especially with the morphine. There are numerous studies into which explored into this aspect of morphine, and it is being said that it has been shown that morphine is associated with Purkinje cells dendritic length survival. The longer duration of morphine exposure leads to decrease in Purkinje cell size and the number, and associated with reduced cerebellar volumes, and in turn resulting in poor motor and cognitive outcomes. So this was a study which showed the very preterm neonates who were exposed to morphine, their effect on cerebellar growth and the neurodevelopmental outcome. So they studied 136 very preterm neonates ranging from 24 to 32 weeks, and then they did MRI at the term equivalent age. The parameters were looked into volumetric measurements of the cerebellum and the cerebrum. So the motor outcomes were assessed and the cognitive outcomes were assessed. So the results the results were a tenfold increase in morphine exposure was associated with 5.5% decrease in cerebellar volume, and when the effect of glucocorticoids were excluded, the association of morphine was more pronounced, with a furthermore decrease in the cerebellar volume. And morphine exposure was also associated with poor motor control and the cognitive outcomes. So morphine was and it was concluded that morphine in very preterm is independently associated with impaired cerebellar growth in neonatal period and poor neurodevelopmental outcomes. So this is a very landmark trial, neopain randomized trial, which studied the effects of morphine analgesia in ventilated preterm neonates. So morphine was compared with the placebo. The composite outcome and the other outcomes of neonatal death, severe IVH and PVL, were similar in both placebo and morphine group. But the intermittent boluses of open label morphine was associated with an increased rate of composite outcome. And so the preemptive morphine infusions did not reduce the frequency of severe IVH, PVL, or the death in neonates. And also the intermittent boluses of open label morphine was associated with increased risk of composite outcome. So the morphine doses used in the study decrease clinical signs of pain, but can cause significant adverse effects in the ventilated preterm neonates, according to this neopain randomized trial. So Cochrane is for opioids for procedural pain in neonates, published in 2023. So in both preterm and term infants with a PMA up to 46 weeks who were exposed to procedural pains, including opioids, were compared to placebo or no drug and other non-pharmacological interventions and other analgesics and sedatives, other opioids, and same opioids administered in different routes. We'll see the comparison of, so this is a forest plot showing the comparison of opioids versus no treatment or placebo. So the outcome measured was the scoring system, pain profile, a revised pain profile scoring system was used. This is for during the procedure, when the procedure was done. So if you see the cumulative effect size, the diamond is in favor of opioids with a mean difference of 2.58 with a CI of minus 3.12 to minus 2.03. So it was significant during the procedure. But the same comparison between opioid versus no treatment or placebo, the pain scoring was done up to 30 minutes after the procedure, and there was no effect. There was no significant effect seen. So you see, so which affected did not last beyond 30 minutes. Okay. So, so the newer drug dexmedetomidine for analgesia and sedation in neonates, a systematic review of efficacy and safety was done, and it was done in 2022 September. So it used 6 studies involving 252 neonates, and it suggested that there was no significant adverse effects associated with dexmedetomidine were reported. But well-designed studies to establish both efficacy and safety of dexmedetomidine in neonatal care are needed. So now coming to few slides on withdrawal. Now, opioids, which are potent analgesics, which have been used quite a lot as a psychoactive property, for its psychoactive properties over centuries. And if you see pregnant women contributing to a surge in utero opioid exposures, both prescription and illicit use, which was associated with adverse neonatal outcome. And in last 10 years, from 2004 to 2014, the incidence of neonatal opioid withdrawal syndrome or the neonatal abstinence, there has been 500% increase in the incidence. Neonatal opioid withdrawal possesses a severe health risk as the neonates experience wide range of symptoms. We'll see what are the symptoms of withdrawal we can see in the neonates. So the nomenclature, just to understand, neonatal abstinence syndrome is used to describe withdrawal from variety of substances, most often opioids. And neonatal opioid withdrawal syndrome, which is the term used to indicate withdrawal from opioids specifically. And maternal neonatal opioid withdrawal syndrome is used when there is prenatal or in utero exposure to opioids. And iatrogenic opioid exposure is iatrogenic opioid withdrawal is if a neonate is exposed to opioid postnatally, which is usually part of clinical treatment. So this is the terminology. So maternal neonatal opioid withdrawal and iatrogenic neonatal opioid withdrawal. So these are two different entities. You see the prenatal exposure, which is maternal neonatal opioid withdrawal syndrome. The few contributing factors like gestational age, IUGR, cumulative uh, opioid dose taken by the mother to which the neonate is exposed, methadone use, and there are psychotropic drugs and the tobacco use. There are few diagnostic tools for maternal neonatal opioid withdrawal, like Finnegan neonatal abstinence score. There has been many modified and simplified version of Finnegan abstinence score. There is also called mother neonatal abstinence score, eat, sleep, console method. So these are all the diagnostic tools for scoring the symptoms of withdrawal. Now, if you see symptomatology, all systems, predominantly gastrointestinal symptoms, which may include loose stools, excoriation, poor feeding. CNS includes hyperexcitability, tremors, increase in muscle tone, excessive crying, and difficulty in sleeping. Respiratory symptoms include sneezing, tachypnea, and nasal stuffiness. So now coming to postnatal exposure, which is usually after a medical treatment when the neonate is exposed to opioids when on prolonged duration of ventilation. Uh, Usually the contributing factors are opioid exposure if beyond 96 hours, uh, there is withdrawal, and fentanyl use have been associated with withdrawal symptoms. To assess this postnatal exposure, there are specific tools like withdrawal assessment tool, SOS scoring system is there, and there is altered Finnegan neonatal abstinence score. Symptoms are more or less similar with the prenatal exposure. So in all neonates requiring sick neonates requiring prolonged duration of ventilation and sedation, otherwise ruling out sepsis and other common things. If neonate has these symptoms, then definitely we have to consider iatrogenic opioid withdrawal as one of the differentials. So we'll just see two scoring systems for opioid withdrawal. The Finnegan neonatal abstinence score, it has a 21 signs and symptoms. I'll be seeing in the next slide what are the signs and symptoms. And if the scoring is above 8, then we have to start this pharmacotherapy of oral morphine. It is in the tapering dose of oral morphine. It has been widely used in American countries and European countries, and there has been some modified and simplified version of Finnegan NAS. The only drawback is it is not for the preterm. It cannot be used for the preterm, but can be used for ventilated term neonates. The other simple version is the eat, sleep, and console scoring system. It's a very simplified scoring system, which includes eating, sleeping, and ease of consoling, 3 parameters. It has been shown that it drastically reduces the length of the stay because, the only thing is, in sick neonates who are ventilated or critically ill, this scoring system cannot be performed. So there are few limitations of both Finnegan and Eat Sleep Console scoring system. So if you see the modified Finnegan used for neonatal abstinence involves all the 21 parameters and includes central nervous system, respiratory and gastrointestinal symptoms. So based on high the severity of symptoms, you have to score it. So knowing that neonates are subjected to prolonged ventilation and sedation, and they can have this withdrawal. So we have concept of weaning. So when should we wean? How should we wean? And which? And sometimes in neonates we use uh, two or three sedations. So which one to taper? So during weaning, weaning should be performed when any neonate is on continuous opioid infusion and is planned for and receiving sedation for 3 or 5 days or more. So you have to consider weaning. How it has to be, there has to be steady reduction in the dosage. We'll see how fast we can decrease the dosage, and it has to be very intermittent, not very drastic change. And among all the sedations, benzodiazepines are first to be weaned, followed by opioid. And while weaning one, you should not wean the other sedatives. Concurrent weaning is to be avoided. So the steps of weaning, while weaning any sedatives, we have to do a complete neonatal abstinence scoring assessment, which we have seen, or eat sleep console, whatever is convenient. And then if the score is less than 8 for more than 24 hours, then we should consider weaning. And the weaning, how much should we taper? It varies. There is no strict guidelines for how much to wean, but usually, if the neonate is on ventilator, received a sedation for 5 to 7 days, you decrease by 20%. And if the duration of sedation is above 1 week, you can taper it by 10%. And the weaning should be every 24 to 48 hours. And if at any point the score is more than 8 for 3 intervals, or the score is more than 12 for 2 intervals, you have to consider increasing the dose by 10%. Or you have to go back to the previous dose on which the neonate was. So there are no guidelines by any organization how to taper, but this is Newborn Critical Care Center clinical guidelines, in which they have given some instructions regarding weaning of sedation for continuous infusions. So if a neonate is on fentanyl infusion for 2 weeks or less, then consider weaning by 20%, and that weaning has to be over 5 days. And if fentanyl infusion was given for more than 2 weeks, then tapering has to be slower, around 10%, and it has to be tapered and stop over next 10 days. And at any point, there are symptoms of withdrawal, then we have to increase by 10% or go back to the previous dose. So now, we have come to the end of the discussion. So there are few future directions where not all units are using this pain assessment score while performing any venipuncture or heel lance or even intubation. So there has to be a standardized approach for quantifying the pain assessment, be it the scoring systems or other newer aspects like NIRS or EEG to detect the response to pain. And there has to be a protocol in place in every unit for analgesic approach to analgesia, which analgesics to be given for both term, preterm, male and female. And not many studies, apart from morphine, is showing the long-term effect of pain on brain maturation and neurodevelopment that has to be there. And yeah, this the most important aspect is all units has to have this weaning protocol of analgesics and sedatives, because they get into withdrawal if there is sudden stoppage or abrupt cessation of the opioids. So with this, I conclude my presentation. Thank you.